Today, I will be discussing with you all why additional regional anesthesia for laparoscopic surgeries is an absolute winner. We are all aware that laparoscopic surgeries are better because they cause less pain and less discomfort. The blood loss associated during laparoscopic surgeries is much less. The return to normal function is faster. The wound-related post-operative complications are minimal, and the quality of life outcomes are amazing. Most of all, it helps us achieve enhanced recovery after surgery. So, talking about ERAs, there are several techniques that we can adapt preoperatively, intraoperatively, and postoperatively. Talking about the intraoperative things that can be done, epidural analgesia and minimally invasive approaches are something that take a top seat. In the postoperative period, we want to prevent postoperative nausea, vomiting, as well as postoperative ileus, assure good postoperative analgesia, and early mobilization to enhance the recovery after surgery. So, how will that help us when we use regional anesthesia? So, do you know what is the most common reason for readmission after a laparoscopic surgery? Yes, that's nausea and vomiting. And the second most common reason is pain. So let us understand a little bit more about pain after laparoscopic surgeries. The pain after laparoscopic surgeries is multifactorial. One of the main reasons is the incisional pain from the port site. There can be referred pain because of the peritoneal stretch, the visceral pain because of mechanical traction, dilation and spasms, inflammation, ischemia, and chemical stimulation. So when we have this multifactorial pain, the way to deal with it has to be multimodal. One of the most important part of these multimodal analgesic regimens become opioids. But the problem with using opioids will be nausea, decreased bowel motility, delayed recovery, and increased length of hospital stay. All of these things are something that we don't want to assure enhanced recovery, right? Not just that, these opioids, because of the problems that they create, will increase the cost to healthcare and worsen the patient satisfaction. But is the pain really that bad that we will end up using opioids? Oh, yes, absolutely. There is enough literature which shows that even a seemingly simple laparoscopic cholecystectomy is associated with moderate to severe pain. And this, despite all the currently available multimodal analgesic regimens. In fact, there is this study which tells about Denmark, which does about 9,000 cholecystectomies annually. And 93% of these are laparoscopic and 40% are aimed to be performed as ambulatory surgeries. Approximately 15% of these ambulatory patients, however, cannot be discharged because of the two reasons that we spoke about, pain and post-operative nausea and vomiting. Not just this, the pain following laparoscopic surgeries in the first 24 hours is in fact worse than open laparotomy, the pain associated with open laparotomies. Although the pain with open laparotomies will become, worse in the next 48 to 72 hours, but these first 24 hours are bad during after laparoscopic surgeries. And the intensity of the visceral pain is much more than that of the incisional pain and the shoulder tip pain. So all this translates into increased opioid requirements. Opioids and the pain mean that the postoperative nausea vomiting will increase and PONV in itself will aggravate the pain. So this all becomes a vicious cycle in itself. This adequate pain management, which is based on decreased opioid usage, becomes one of the cornerstones of ERA's protocols. And to achieve that, regional and neuraxial techniques form a very important adjuvant to the multimodal systemic analgesic regimen for better pain control. In fact, there are several review articles, there are systemic reviews, meta-analysis, RCTs that will tell us that single injection peripheral nerve blocks with a long-acting local anesthetic alleviate much of the severe post-operative pain after laparoscopic surgery and facilitate same-day discharge. More so, the more central abdominal and thoracic wall blocks, such as the erector spinae blocks and QL blocks, alleviate the incisional pain as well as the visceral autonomic pain. And these are associated with low pain scores, not just at rest, but also during movement in the first 6 to 24 hours post-operatively. If we end up adding longer acting local anesthetic like ropivacaine or bupivacaine, add some additives like dexamethasone or dexmedetomidine, and the action will last for almost up to 20 to 24 hours. And like we discussed earlier, laparoscopic surgeries is associated with the most severe pain during the first 24 hours. So this translates into lower intraoperative and post-operative opioid use and lower rescue analgesia within the first 72 hours. So if we have got more clarity into what I've been talking about, we understand that when we are using regional anesthesia for post-operative pain management after laparoscopic surgeries, this will give us better pain control. The opioid requirement will decrease, which will mean early mobilization, a faster return of bowel function, reduced length of hospital stay, and decreased nausea and vomiting. All of these would help us achieve ERAs. When I'm doing this, my patient is better satisfied. The readmission rates are minimal and the cost to healthcare are absolutely less. So why will I not give regional anesthesia after laparoscopic surgeries? Isn't this an absolute goal? I will leave this in your court to decide whether we should go for regional anesthesia or skip it. Thank you.